Actually, it has now started being recorded. All right, so let us start by defining EHR. What is EHR? EHR is electronic health record, which is the systematized collection of patient and population electronically stored health information in a digital format. These records can be shared across different healthcare settings. So the next question would be, okay, what's the difference between EHR and EMR? So it's easy to remember the distinction between EMR and EHR if you think about the term medical versus the term health. An EMR is a narrower view of a patient's medical history, while an EHR is a more comprehensive report of the patient's overall health. Don't get me wrong, I am not taking anything away from the medical practitioners. It's absolutely a very critical pillar of the whole value chain. I'm just making sure that things are discussed in perspective, and the full scale is appreciated by the audience. So now, on this diagram, we have the different stakeholders in the pie of healthcare service provision, or let's just say healthcare, full stop. So here, let's start with on the bottom right here, what we just called others. This is just the communities we live in, people, and these may or may not be patients. They may or may not be on medical aid. It's just an ordinary population. And then the next pillar, the service providers, your doctors, your hospitals, pharmacies, laboratory specialists, scientists, and the wide array of disciplines in healthcare service provision. It's a very long list. And then on top are the funders. Now, they are not on top because they are the most important. It's just a coincidence that the diagram put them on top, but the funders are the ones that come in, and on some arrangement, they pay for the service provision. That's why they're called funders. In some countries, they're called sponsors, or they could be called insurance, or they could be called aid or medical aid societies. But these are all funders. Then, of course, funders have members. These members may become patients. So this then becomes the full journey of value addition in health. So in the middle here, it says Utanox, healthcare platform. Well, Utano is a Shona word for health or wellness, and the X stands for exchange. So I just want you to paint this picture in your minds that these different stakeholders are then connected to make a healthcare exchange platform, which is what makes then electronic health records our main discussion, because you can only have healthcare or wellness data exchange if you have, in the first place, adopted an electronic health record of one kind or another. So now, I just want to give you all an appreciation of the benefits of the digitalization of healthcare. So now, these figures, the source is ourselves. We did not get this from another publication or from another organization. I was going to cover this later, but maybe I should I should quickly just jump to this to this to this slide so that I am so that I bring about an understanding of where we're coming from and why we feel that it is our duty to do something about it, to spark this discussion. So now we are coming from a background where we have over 900 healthcare sites that are running on our platforms. These cover pharmacies, doctors' rooms, specialists, hospitals, ambulances, health insurance, funders, laboratories, etc. And our platform is hosting well over 1 million patient records. And we've been beyond testing and in a live production status for over 10 years, and we are present in three countries at this time, all in Africa. However, we are quite exposed to other countries beyond the countries we're in, beyond Zimbabwe, Botswana, Zambia, Rwanda, Tanzania. We were quite exposed because we all the time discover that there is a strong need for the solutions in our category, whether from ourselves or from others. However, you find that there are many inhibiting factors, which is what we intend to eventually cover. So now, having said that, let me go back to the slide where I was. So now it is from the background of our exposure with the different facilities that we've done a quantitative and qualitative analysis of the difference in terms of a digitally run healthcare facility and a manually run healthcare facility. Now, I know that it maybe sounds a bit silly for us to make this comparison in this day and age where everyone is on Facebook, WhatsApp, in the different technologies. But you find that even though a person will personally be adopting technology in their private life, you might find that in their practice, they probably do not, for one or other reasons. And we hope to eventually debunk the myths, the fears, the concerns, the worries on the subject, so that you can be placed in a position where you're more likely to make a less prejudiced decision. I mean, at least if you choose to stick with paper or manual systems, at least that would be an informed it would no longer be a matter of didn't know the gun was loaded. It would be a matter of, well, I'm fully aware of what is possible. However, this is my choice, which is what I consider a more ideal place to be in. It's from my personal philosophy, that's an empowered position from which to take up the discussion. So this chart here in this deep orange color is automated system, and in blue color, in the sky blue color, is the manual system. Now, understand that what's called a manual system, it varies. And it can be manual as in you are using paper cards. That's very manual indeed. I think we can all agree that is manual. Then from there can be more structured paper systems. It will still be paper, but more structured. If, for example, I'm sure you've all seen in government hospitals where they've these huge registers. That's actually a system. It's a manual system, but it's a system. See, it's already better than a counter book. It's better than an exercise book. So that's a manual system, but it's an improvement because it's more structured. The data that is put in there is easier to analyze. It is easier to decide upon. It is easier to to direct the process of healthcare service provision. So now the way we built this graph was we actually did the numbers based on our exposure, reminding you that this is from over 900 facilities and over a decade. And we did the numbers in terms of the time taken by a patient. In fact, another study shows that 60% of the time used by the clinician is used in administrative work, not patient care. 60%, that's more than half the time. This is covering all clinicians, from nurses, doctors, and other categories of clinicians. So now from our study, we looked at, there are 4 categories here. And the first, we were looking at the context of sponsored or insured patients or medical aid patients. And we looked at first at the first pillar on the very left here. This one was looking at benefits verification. Now, I know that it's not all countries that have medical aid. I fully appreciate that. But from what I understand, there is a general drive to have most countries, most populations, at least exposed to the option to be on a medical aid scheme of some sort. And yes, the recent COVID situation did trigger some of these necessities or exposed the gaping holes in access to care. So while this issue probably is obvious in societies or settings where there is a significant percentage of the patients who are coming in covered by insurance or medical aid or funding scheme of some sort, this is where the first problem comes in. So my colleagues in Zambia, I know that there's a lot happening there on the subject. I know that just recently in South Sudan, they just recently had the first medical aid. And I know that in Tanzania, there's a lot of medical aids. And I know that in Botswana, there are many medical aid societies as well. So I know that the issue of medical aid benefits verification is an issue because one wonders whether or not the patient who is holding the card is the legitimate holder. And then if they're the holder, the next question is whether they still have benefits which are still active or not. So this is the first place where you have a massive difference. As you can see, all this is a big difference. And it's a difference in terms of time, because what happens that without a system, one is to manually contact the funder or send the patient back to the funder to get a letter signed and authorized and stamped as proof that they are a bona fide member in the active benefits. Of course, this may be the last resort, obviously. But all that is downtime. This is healthcare we're talking about. Then the less manual process is probably making a phone call to the medical aid and inquiring on the medical aid status. That's less manual, but still it's manual. And what we are comparing with is something which is automated. In other words, the card is just scanned and immediately one knows the status of their membership, at least membership, ideally benefits as well. That is, in other words, get a quotation verified or ratified by the medical aid as something that they're guaranteeing that they will pay. There are more issues we'll touch on in later webinars, where we talk about what are the chances that after you get that quotation authorized, is it still possible that the claim may be rejected? Well, this is a discussion that by itself will take its own 1 hour plus. All right, continuing on this graph, the next step is file retrieval, which is either you're pulling the record from a computer or you are pulling the record from a paper card system. Now, I've seen healthcare facilities where their card indexing systems are so efficient that they're actually pretty fast. And they're so fast, you'd, for a moment, think that they don't need computers. For a moment, of course, it's not exactly the ultimate decision, but we have seen things like that. So this, again, you see a big difference here. The next step is the point of receipting. And this is probably not so much to do with the actual delivery of care, but let us not dismiss the issue of receipting, because healthcare facilities, they have to be viable. They have to be viable. Their expenses, their people, their staff, their generators, their equipment. So we cannot underplay the importance of collecting payments for the services. This is important. And then the next pillar is healthcare records. In other words, the rest of the clinical details, like previous notes made on the patient. So now this is difficult to graph, you see, because with a card system, it may be entirely impossible to get records from other doctors that saw these patients in the past, you see. It may be, or maybe the patient comes with a card that already has some notes, but the comprehensiveness of that record may not be what you desire, because a clinician, a doctor would ideally, or closer to ideal, want to see even pictures like scans, lab results. They'd want to see all the notes made by previous caregivers, the outcomes from there, from that, the prescriptions, because bear in mind that sometimes the patient is not able to speak, or even if the patient can speak, you cannot get all the records from the patient, because this is technical, this is clinical data which the patient does not necessarily comprehend. In fact, typically does not comprehend or does not want to comprehend. So this is just to give you a quick overview of the difference between a manual setting and a digitalized setting, but with the appreciation that manual is relative. What you call manual can be called a system by someone else, you see. Whereas what you think is a system can be called manual by someone else, because there are different grades, the different points where you have the opportunity to automate or digitalize. And, you know, resources permitting, or other factors. Maybe it's not resources, maybe it's confidentiality concerns, maybe it's willingness to take up the solutions, maybe there are many factors which we are going to cover in future webinars as well. So here are some of the lessons learned in terms of what it takes for you to automate your facility or your practice. Now, apart from you yourself making the decision, there's the issue of the buy-in of the users. This is a very, very important factor, because you have your team on the ground, the caregivers, the admin personnel, and they have different levels of, 1, literacy, 2, computer literacy, that is 2, readiness or willingness to have a computer be involved in their processes. Another factor is you may find that maybe the doctor wants everything to appear on his tablet, on his or her tablet, but the nurses are not very willing to enter the vitals in the tablet. So in the end, the doctor is there, but the rest of the team are not there yet. So the doctor is now forced to continue relying on the manual notes or vitals taken by the nurses, because the nurses are not putting this in a computer system. So the buy-in of the users is probably the most important aspect. You might be surprised that it's probably more important than even finances or budget, because you know the old phrase, where there is a will, there's a way. So the will would be missing in the users, then the way becomes also missing automatically, because there's no willingness. At the same time, from what we have also discovered is that the reason users might not buy in is not because they outright do not want a system, but you might find that they are short-staffed. I'll give an example. One hospital, they adopted our system, and in the labor and maternity wards, they have so much traffic. Even with the paper admin, they sometimes they have to sort of do that when they get a moment, because there's just so much to attend to. They have patients, and they have so many situations happening in the ward, and they are more or less short-staffed. The system is there. When they get the time, they get to the system. You see now, this is when they get the time. So in this case, you find that the nurses were, and the midwives were, they were happy with the system. They could see that the system was going to make their work, but the sheer volume of activity happening in the ward was just making it impossible. So in the end, what they needed was actually an additional person added as a data capturer, which works. Another option, of course, was to just add more personnel, but the truth is, right now there's a global scarcity of caregivers in healthcare. That's just a fact. I don't think there's any country right now that can boast that they've enough. There isn't. In fact, there never has been on the planet ever. So now the problem has only become worse just because of the recent situation. Otherwise, there's never been sufficient caregivers. In fact, one study revealed that we had only about 10% as many caregivers as we need, which was before the pandemic. Now it's worse than that. All right, so now we covered the buy-in of the users, but this is very important. And what we then propose is that through a seminar or a webinar such as this one, you then craft what I might call a syllabus internally, whereby you begin to one, educate. That's a starting point. Just educate your team on the things we talked about in this webinar. And I can assure you that merely playing this webinar to your team is a good place to start. It will make a difference. The problems we are sharing with you are first-hand problems, things that we've seen, not just read about, things we've seen in very, very, very trying circumstances, where perhaps we're even doing night shifts, hand-holding users, sometimes in remote, sometimes modern places. So a starting point would be just an education of your teams, so that at the very least you are on the same page in terms of viewpoint, in terms of attitude, in terms of belief systems. Just bring everyone onto the same page, so that at the very least there's an agreement on the concept of having a digitalized healthcare facility. And bear in mind that if this education is not done, it might look like someone is sabotaging the project, but it won't necessarily be sabotage per se. It will be just, I don't understand what you're doing. I don't know how to support you. I don't know how to help you. I don't know how to cooperate. And I don't know if what you're doing is not going to replace me. You see what's going on here. So now, once you have the thinking that the system will replace me, then I cannot be very cooperative, can I? That's just factual, right? It's factual. It's a reality. We're families to feed, you know. We have to put something on the table. So an education is very important, and that's a starting point. You start by educating your teams, bring about an understanding of the fact that where you're going is a better place than the place you are now, and plan like make a program. And this is where we come in. We can help you craft a program, a transition program. It could take a while. It could take a year. It could take 2 years. This would be a preparation program where you are not even committing to any financial resources or any budgetary items in terms of technology, but you're just committing to a transition of the internal culture, or a transition of the mindset, or the viewpoints in your team, so that you have a predisposition or a willingness or a desire to be helped by technology. This is very, very, very important. It's very important because you find that if someone loves something, they will put their energy into it. They will commit time to it. They will burn the midnight candle studying how the new system works. Why? Because they love it, you see. So the first point is education. It is giving an assurance. It is giving a job security to the team. They have to understand that the technology is coming in as a partner to further guarantee them their work. It is a technical partner. It is not a replacement. I can assure you, we are very, very far from being replaced by machines. I'm telling you this from a background of also having attended many webinars, some hosted in countries such as Netherlands, some as in the US, and some in countries where you would assume that they are the most advanced. But I can tell you that globally, we are very far from worrying about being replaced by computers, and definitely not in healthcare. You might have self-driving cars, but caring for a human being is an entirely different activity. So my point is that on the issue of buy-in of users or buy-in of your stakeholders, this is an activity you need to be very, very intentional about. We actually come up with a program or a syllabus where you systematically bring about an understanding, an appreciation, a recognition of the value that comes from using technology. So now, healthcare provision is because of the complex or sophisticated nature of the problem. You find that there is a wide range of skills, education that is required to cater for a patient. For that reason, you find that on one patient case, there's a wide range of differences in terms of educational backgrounds or exposure to technology. However, this does not then translate into a relevance in terms of the actual caregiving. No, I can assure you that a midwife is incredibly valuable. Now, whether the midwife is capable of using a computer system or not is entirely irrelevant. I can tell you that. It's entirely irrelevant. It doesn't matter whether the midwife can use a computer or not, because midwifery is the oldest profession. You don't even need electricity for that. And my point is, these are the eggshells you're working on as you're selling the idea of digitalizing in a facility, because it is easy to be misunderstood in your motives. While you're coming in from the angle of increasing the quality of outcomes, or to increase the viability or increase the efficiency of the service provision, it is possible that the signals you are sending are misunderstood. And this is something you must not underestimate. It is something you cannot underestimate, because unfortunately, not all of us will express directly our disagreements. Because of different backgrounds, I won't necessarily tell you that I disagree with what you're talking about. Maybe I'm my boss. I can't tell you that. I cannot tell you directly. Or because of other background, let's just say perhaps maybe other politics. I can't tell you directly that I don't necessarily understand what you're talking about. Maybe I'm afraid that if I say that I don't understand what this war system is about, I'm going to be fired, which is not the case, you see. However, my point is the war subject has to be introduced in a palatable manner, in a manner which it can be received, accepted, understood, and supported. Sorry, I just had to clear my throat there. So yes, I'm weighing in on the subject of buying of users, and excuse me. Yeah, as we proceed, if anybody has anything to share, feel free to jump in. It's totally fine. We want this to be a very permitting atmosphere, and you can all just jump in and share any of your experiences. Perhaps half of the people in this seminar are already exposed to systems, and some have already adopted systems. So I'm pretty sure that everyone is a few things to share on the subject. All right, I'll proceed. The next issue is the issue of the buy-in the buy-in of facilities admin persons. So now here we sort of covered some of the issue when I said buy-in of users. I just wanted to separate here users versus admin persons. I think by this I'm talking about the management of the facility. So you might find that maybe management is decided they want software, but users have not, or vice versa. Users, the operational team is 100% sure that they're better off with systems, while the management is not so sure. It can be a bottom-up problem, or it can be a top-down problem. Either way, it's a problem of buy-in. So this one, I've mostly covered it, but some of the issues have also been covered when I presented the graph where we did a comparison of a manual versus an electronic system. However, what we're actually going to do in future webinars is to take these up one by one and cover each one as a separate webinar. So that way we thoroughly cover it, because I can assure you each one is actually it's something worthy of attention on its own. Each one is a very important subject. All right, so now I want to go to issue number 3, buy-in of the clinicians. So again, we've covered some of this under users, but I just wanted to separate clinicians versus administrative personnel. So for example, you find that people in billing, I don't know if I should say usually, because sometimes it's the opposite. But in many cases, you find that the people in billing are quick to recognize the need for systems. They are probably already using other half automated systems, perhaps Excel, but they already see the problem, you see. So they now want a dedicated, specialized system. However, that's just them worried about how to keep records of payments and follow up on medical aid shortfalls and so forth. However, you find that clinicians, their primary care is the patient. So the moment a doctor feels that a system is going to stand between them and their patient, or is going to be a distraction from patient care, then I can tell you that the system is the one that will go, because their heart is with the patient, you see. So the buy-in of the clinicians is very special, it's very important, and it's very sensitive, because after all, the primary reason everyone is there is because of the clinicians. That's the primary reason why the whole facility is there. Without the clinicians, there's actually no facility. In fact, you could remove everyone else and only just have the clinicians. So the buy-in of the clinicians is very important, even though I've seen that in many cases they are sort of disregarded, and the entire discussion is done without them being involved. And sometimes they themselves don't care. They are satisfied with this position. But as we'll cover later onwards, they are very, very, very important part of the puzzle. They are the important part of the puzzle. In a moment, I'll be illustrating why they are so important. Yeah, because the worries and the facilities there is because of the care that's been given. And then the next point is the importance of connectedness. This is a lesson we've learned, that it's very important for the entire ecosystem to be connected. Right now, this is far from being the case worldwide, I can tell you that. In countries where you imagine that they are already there because maybe they already have 5G and they have good internet, they actually have new problems there. They have new problems because the platforms that have been endorsed or enforced by governments are not trusted by citizens, and citizens have put up privacy demonstrations, and they are opposing the systems. And this is in places where you'd assume that, come on, this is the first world. But I can assure you, everyone is grappling with a unique problem, a problem that applies to them. Eventually, yes, maybe you could say we'll eventually be grappling with those. Maybe those are better problems to have. Maybe. That's just a maybe. I cannot guarantee that they are better problems to have. But it's very important to have connectedness. In other words, involve the patient. In this forum we're having here, no one was invited primarily as a patient. We actually have a platform that is specifically for patients themselves. A platform where patients, as patients, can keep track of their own records, you know, for themselves. But that would be a different webinar where we invite people, just as people. Whereas this one is more to do with people that are involved in the care provision part of the value chain. So, however, we've learned that it's very important to have connectedness. Involve the patient, let the patient be aware that there is a system that we're using in this facility. And if the patient is involved in the system, it can help us to probably be aware of the developments with the patient. Maybe when the patient is at home, maybe it can be easier for us to be made aware of or to connect the patient with caregivers, with doctors. Things like telemedicine becomes possible, you see. And you find that it also lessens the workload. Just going back to point number 1, 2, and 3, one of the main reasons is because technology gets resistance is because it comes through as a bottleneck of some sort. Now the doctor, instead of talking to the patient, they're talking and typing on the computer. That becomes a distraction, that becomes a bottleneck in the process. Or maybe the internet is a bit slow, or maybe the system itself is a bit complicated, maybe it's slow. So now when that happens, I can totally understand when there is, I might call it a resistance from the user. There's a valid reason there. But you see, when the patient is involved, the patient carries some of the load because the patient can actually capture their own demographics, their identification information. They can capture their own history, their own family history. They know these things, you see, because remember, you were going to ask them for these details anyway. So you can trust them with their own details because you're going to ask them. So if you're going to ask them, why not just let them capture on their own, right? So it's very important to involve the patients, because when you involve them, that is one of the pieces of the puzzle we are solving in the overall problem of EHR, electronic health records. Well, after all, while the clinician is most important, the clinician is attending to the patient. So we are all gathered here because of the patients. We cannot underplay their relevance when they are the reason why we are all gathered here. All right. So the next lesson we've learned is the need for low-cost infrastructure. In other words, when you say infrastructure, we're talking about the various things or factors or things that are involved in the in enabling the system to function. So, for example, we're talking about one classic one, the internet itself. So, one lesson we've learned is that if any EHR system is going to be adopted, that system must not require a super fast internet. It must not assume that you are on 4G, 5G, you are in Sweden. No, it cannot assume that, because I'm not in Sweden. The system has to be built to be light. It has to ideally not require everyone to buy a server, because a server is a very expensive piece of equipment. Not just expensive, but it also requires special security, special backup, protection, housing, it's a project on its own, which can easily be more expensive than the whole facility itself. So one lesson we've learned is that it's very important for whatever is being considered to be of low cost. So now the next factor is simplicity of use, the user interface or the user experience. And I put here in brackets, I said natural. So we are saying that we envision a system that is as natural as possible. So now there's a fine line in this, because the most natural would mean that you're not even typing on a keyboard, right? It would mean that as you're, for example, when the doctor is consulting a patient, as they are speaking, the conversation is automatically recorded as the patient notes. That's the most natural, right? That's the most natural. It doesn't bring about a disconnect between the patient and the doctor. And at the same time, it is not intrusive. It is not, because sometimes you have a patient complaining that the doctor is talking to his computer, not talking to the patient. They feel that it's no longer personal, and they leave for that reason. This happens. It has happened. So ideally, you want something that is as natural as possible. And ideally, yes, you don't want the doctor to have to sit down after the patient is gone and then start doing admin, because then that means they cannot be seeing the next patient. So ideally, it should be as natural as possible. It should mimic the natural operation of the doctor as possible. So these are some of the key lessons that we've learned on a very high level. But as I already indicated, each one of these is a webinar by itself, or even a series of webinars. Because, for example, when I talk about low cost of infrastructure, we would now go into the procurement processes of how to judge for yourself whether this is the appropriate internet connection or not, how to measure, how to compare the prices or the packages, the bundles offered by the different service providers, whether I want to tether from a phone, whether I want fiber. I can assure you it is a webinar on its own, and yet a very important one, because if you cannot secure the infrastructure, then you cannot have the technology. We want you to have the technology, right? Any one of these would be a seminar on its own. So now I'd involved recommendations for a Minister of Health. However, I won't be covering this because time is already very, we pretty much have just 20 minutes. So in that 20 minutes, I mean, we've quite a bit to share. We've had sessions with government before, so we're already very, very familiar with their concerns, their interests, their worries, and their challenges in pushing an electronic health record system in different countries. And the challenges are similar in the same region of the continent. However, they can be unique in certain countries, but they're very similar. So there's actually this is a very, very long webinar on its own, the role of the ministry. So now I want to go to all this will be covering the ministry, and also the role of academia. Academia is very, very important. It's so important, I cannot emphasize it enough. But I'm just showing you this so that you appreciate the roadmap of where we're going, so that you appreciate that we intend to take this very far. There are many, many things to discuss in this, because we want to be in a connected relationship with the ecosystem, so that value is offered and derived from different angles, and in the end, everyone finds something that they derive out of these discussions.
Hello, sir. We cannot hear you. May you unmute?
Okay, sorry. So I was asking if you have any questions that we can take up before we proceed, because I said so much, and in the next few minutes, I was going to go over an illustration of what you could expect as an example of an electronic health record system, a one built by ourselves, the one I mentioned earlier that is present in over 900 healthcare facilities and more than one country. And it could at least be our basis for some further discussions. But the way we are pushing these webinars is an open-minded approach. We want to welcome and invite others to also showcase what they have. So I'll just pause for any questions or contributions. Go ahead. All right, I'm going to assume that we don't have any questions. That's all right. I'm going to proceed to demonstrate to you one EHR solution. Now, because of time, I'll not be able to show everything because it's quite comprehensive. All right, so this is the login page. So I'm hoping you can all see that we're on the same page. So I'm just going to log in. So, okay, so for starters, as we mentioned earlier onwards, this solution does not require you to have any infrastructural commitments which are major. You don't need to buy a server, and you just need a basic device that can access the internet. Device, I use that word because you can be using a Windows laptop, even an entry-level laptop. You can be using a tablet, an Android tablet. Can you be using a MacBook? Any of those will be able to access the platform because it is web-based. We provide the infrastructure. The physical infrastructure is actually hosted in Singapore. Singapore, because it is actually where most of the world is going to in terms of data centers. They have developed their data center technologies over time, and now we find that even big brands such as Amazon are actually now dependent on Singapore more than the US for data center infrastructure. So that's where our platform is hosted. All right, so I'm going to log in. So on my dashboard here is really just a list of apps or modules that I possibly can use in my practice, in my demonstration practice. I'll just read this quickly. There's appointments, biometric claims and data, client billing, clinical nurse management, dental, dispensary, doctor's orders and administration, family child healthcare clinic, government reporting, graphs and dashboards, HIV module, kitchen and canteen, lab results, online validation, maintenance, labor and maternity, laboratory, mortuary, lab, mother's waiting shelter, rehab, reporting, specialists, stock and purchasing or procurement, system administration, tuck shop. This is now for for a hospital with a tuck shop, theater, telemedicine, vaccination management, and wards or admissions. That's just in summary. Here there's many other commands and features that enable you to control the system in different ways. So to illustrate further, what I'll do is I'll just create a patient so that I can illustrate the point about benefits checking. So the system is actually integrated with the funder systems in notably Botswana and Zimbabwe. We're still working on the other territories. That's also because there's different levels of automation in different countries. You find that in some countries, the discussion is not even applicable because they may not even have medical aids that are locally established, which is where, of course, we can assist. But my point is that's an example of a situation whereby not every feature of the system can be adopted today. So now there's some of them, these are medical aids in their plans. However, these are not the only medical aids that are accepted. It's actually, it accepts any limit in terms of medical aids in any number of currencies. It's just that the ones that we put here on the dashboard are the ones that happen to have the highest numbers of patients. So, it has been optimized in that regard. Let me just quickly switch to a Botswana scenario, and you find that the funders are a bit different. There's Bomade, Bopomas, Metropolitan, Peace Corps, Pula, and quite a few others. So I'm going to go back to Zimbabwe, where I think I have a demonstration patient that I can use. All right, so I'm going to pick up, all right, so there's no limit to how many funders can be included in the system. There's actually no limit. So I'm going to, I'll just take this one. Just because I happen to have a number that I can use for demonstration first. So the first thing that happens is a checking of the benefits or the benefit status. In other words, whether or not this particular person is actually active for benefits right now. So this one's actually not active, see? But you're already seeing that the details, what plan they are on, that the date of birth is invalid. You can also then ask for the patient to show their national ID so that you can confirm. In case there's a problem with the record at the funder, maybe it's outdated, you can double check. You can see when they joined that particular medical aid or funder, so that you know whether there's likely to be issues of waiting periods that's going to prevent you from being paid for the service you're about to deliver. So I am going to skip and just pick up a demo patient that I already have here. All right, I have 10 minutes. I wonder how much I'll be able to cover. So this is the full record of the patient, or rather I would say the main file covering the details in terms of the demographics, as you can see up here, and the funder details. And for example, this one is a cash client, and so it's not only for medical aid clients. It's for any client that you can have, any patient scenario, whether they're, even if it's free. It's actually possible to also cater for even compassionate cases. It's possible to actually cater for them in the system. Then there's additional details, things like additional demographics, next of kin, the main member details. And they can also run things like transaction statement, high level and detailed and data analysis of this particular client. And you can see their receipts history, if they have any receipts from the past. And you can also see the history of the visits that they've had. As you can see here, there's one visit that they've made in the past. And I'm going to open this visit and use that for demonstration. So as you can see here on the left is different modules that are part of this specific encounter of this particular patient. So I will just run through this very fast. One is vitals. All right, so I'm demonstrating you with without the permissions to view this. I am going to remediate this by, okay, switching to that. Okay, good. What I just did there was to switch to a user that is the permissions. So the permissions are very specific. Every user has permissions that allow them to see a specific page, specific details of a patient record, which is of course very important because the healthcare is sensitive. So, all right. So there's vitals, pretty much the standard vitals, you might say. And then this part is actually for COVID-19 vaccination details. We record the things that are generally recorded from exposure, contact history, then the vaccination in terms of the brand, the sender where they were vaccinated, the serial number or the lot number, the batch number. We've pre-recorded the batches that have been that were being released in the past. So we pretty much have those records of what the valid batch numbers of the vaccines have been. And then, of course, whether the vaccination is left or right, we verified the first and second shots, all those details. And then for your booster shots, where tests are done to determine the need for additional shots. All right, so I'm going to go to doctor's notes. So doctor's notes today are presenting complaints and the history of presenting that complaint. And then now you can have a system review which is high level or generalized, or it can be system specific. In other words, you can have say, for example, something that's specific to dental. So the clinician makes some notes on the dental system. And then maybe they make additional observations as they examine perhaps the digestive system. They make some notes there. So that way you have a very structured, a very systematic way of keeping notes. And of course, as you can see, this is very extensible. You can keep adding these things. There's no limit to how many. I mean, all the systems of the body are already there. So you'll be able to cover, cardio, dental, digestive, endocrine, hemato, or lymphatic, integumentary, muscular, nervous, reproductive, urinary. So that way, nothing's left out. And then examination findings, summary, or you can also have a system-specific examination findings. And then maybe the assessment or presumptive diagnosis or impression. So, and then in the case of a dental case, or where the facility is actually dental practice, the specific records that can be made. So a dental module where you then indicate the tooth number, the notes before or the procedure that was done, and the notes after the procedure. Maybe for example, before it was a specific quadrant of the tooth is decayed, and then notes probably maybe there's a filling that's done. So all those notes are then kept for each tooth, and you can have notes for each tooth, since you're indicating the tooth number for each entry that you're making. And you can also additionally add attachments to this record. And then it can also be medical history. This ideally probably would have been, it could have been captured by the patient themselves, because these are questions you ask the patient, whether they're being treated already or for what in the past, what medication, what kind, ever been hospitalized, when, why, past history of heart disease, rheumatic fever, diabetes, bleeding disorder, high low blood pressure, skin disease, like all these things that are regarded as standard medical history is captured in the system as well. And then the next thing would be your your investigations, where you then have, for example, I'll just pick something that's already existing. Say, for example, that's your full blood count, and then you have the records of them of that full blood count. And this can be like, for example, in a situation where you have a facility with multiple units, the lab scientists themselves would be the ones that capture these details, not the doctor. So the doctor is just viewing the results. Because what happens is that after each station has done their part or is contributed to the electronic health record, they then send the patient the next station, and the next station as their own part. So that way the electronic health record is growing and growing with time. All right, so I'm going to, of course, this can be printed or emailed. All right, so after investigations, typically we have diagnosis, and the diagnosis is made according to ICD-10, which is International Classification of Diseases and related health problems. So now the whole library of ICD-10 is already preloaded in the system, so that you don't actually have to memorize anything. You really just have to type a keyword, like I just typed heart, and all the matches to do with heart conditions in the ICD-10 are available for you to find the I would say the best match for what it is that you establish to be the diagnosis. So for example, maybe this is what you found, so you click that. Fortunately, with ICD-10, yes, Mr. Dalio, I see you've raised the hand. Continue, I'm listening. You can proceed.
Is not refreshed. I'm not sure whether it's my system or what. I'm choosing the vitals page.
Okay. Yeah, I don't know if that's perhaps with internet connection, because I'm on diagnosis now. I don't know if others are also seeing the vitals page right now. Someone else can just confirm what they see right now.
I am on the vitals page too.
Okay. Yeah, so let me just stop sharing and then share again. Maybe, how about now?
Yeah, I'm on the patient diagnosis.
Okay. Okay, so I'm assuming that everyone is now seeing the diagnosis page. Thank you for that. So now from there, there'll be a treatment plan. So ideally, we're saying that we're expecting that the doctor is actually giving the instruction to someone who administers the orders, maybe student nurses. Okay, so they'll be entered here. I'll just put something random. I'm not clinical, so forgive my layman kind of description of things. All right. So now, from there, the ones who are administering the orders are now looking at this, following the instructions in the system. So I realize that we are envisioning a scenario where paper is not even used at all. So when the patient gets into the treatment room, all they're carrying is an identifier that enables their record to be pulled out. It can be a barcode tag that the hospital gives the patient to go around, which is based on QR codes, which this system actually prints on its own. That's the ideal scene. Of course, you'd make a judgment based on the resources at hand, but that's ideal, and it is the most seamless. And I think that it also help improve the perception that patients generally have on the facility, the level of confidence they have, and the word of mouth that goes around. One of the main reasons patients keep coming back to your facilities because they are happy that they don't have to fill in paper or answer the same questions again as if no one knows them. So yes, it makes a big difference to have all your patients' records in a system, because then once it's on record, it's on record. All right, so, and then the procedures, the orders are translated into procedures, which are pre-captured in the system, as the system already pretty much knows that a standard M injection is these items, syringes and swab. POP, for example, is typically these items, crepe bandages, POP of different sizes, and strapping. Enema, for example, these are the items that are used. Just giving appreciation, we've sort of preloaded a wide range of procedures, including those in radiology, for example. You find that even CT procedures, they're pre-configured. Medicines, MRI, surgeries, sutures, theater, ultrasound, X-rays. So they're pre-configured so that once you give the instruction to, for example, if you just say it's going to be a bleeding procedure, then it's already known that these are the sundries that should be used typically. And it's also alerting you as to stock levels. All right, so yeah, excuse my speed because it's a little after 4. I know that I'm now in extra time. All right, then from there, you have prescriptions with the instructions that are given. And this prescription can be sent as an electronic prescription. In other words, a code is sent to the patient's phone, and they can go to any pharmacy, and that pharmacy does not have to see a paper copy. They just see the code, they click the link and takes them to the full prescription. This method then prevents abuse. For example, if a patient has developed a an addiction to a certain medicine. Or maybe they have a relative who is addicted to the medicine, so they can steal that prescription and use it to go and get a prescription medicine. However, when it's electronic, it's not possible to do that because the system will indicate that this particular medicine has already been dispensed. So to that degree, you also protect your patients by going electronic. Or maybe in a more sinister example where, say, maybe a patient is taking the medicine and selling it. Yeah, this can also guard against that. And then from that, if admissions, say you are admitting your patient, this is primarily when say the doctor is admitting their patient away from their rooms and they manage the patient while they're admitted somewhere else. They would keep the records here as to what date and time, ward, bed number, diet notes, the names of the caregivers, any special instructions or remarks. And then there's actually a ton of other registers which are used in big hospitals. But first going into these, it will have to be another presentation. Just to be honest with you, a detailed presentation of this system would need about at least 3.5 hours. And if you are presenting everything, including the funders software, then we are definitely looking at something around 7 to 8 hours total presentation time. So we just want this to be probably a quick overview that at least gets you asking questions that we can then answer in future webinars. Then after that, maybe there's a discharge with a note, maybe a sick note is made. And then the billing, of course. In the billing, you have the prices and the payments that have been charged the patient. And yeah, on each line of the bill, you have tariff codes. And in each country, we preload the universally adopted tariff codes. Because typically every country has its codes that it already uses. For example, for consultation in a hospital, consultation at the GP's rooms, consultation at the specialist rooms, all those have different codes to facilitate in payment of claims or record keeping or analysis or statistics. So we preload those ones on a country level, so that when you take up the software, you don't have to do this. However, let's suppose you are operating independent of the country's medical aid system, for example. The system allows you to then have your own tariff code system or your own pricing system in terms of the price codes, descriptions, and the prices, and even the currencies. All these allowed. Say, for example, maybe if you're taking cryptocurrency from patients when they're getting service, the system allows you to do all this because this is your system after all. Then, of course, the most important part of a system is the reports. I didn't get to talk about appointments, but all right. Then anyway, there's reports. There's many reports to do with claims, billing, so that you can keep track of what's outstanding, what's unpaid, shortfall. And then there's analysis kind of reports where you break down the revenue by funding, for example, so that you can immediately see where you're getting most of your business. So there's your breakdown of total of clients by each funder. So you see how many clients came from there and how much it was. And then you have I mean there's numerous analysis kind of reports, breaking revenue by diagnosis, department, by age group, daily revenue, weekly revenue, monthly revenue, registers, aggregates, referrals. You want to know which which other service provider or clinician is sending you the most business. You can actually make that analysis as well. Then there's also reports to do with stocks, the vaccinations, lab results lists. There's many reports. These are just some of the reports. Because we are software engineers, we actually sit with you and establish what it is that you require. If it's not there, we edit, because that's what we do. And we're the custodians of the intellectual property. So we have that we're in a position where we are able to actually carry out your requests. So at this point, I will open the floor for questions. Any questions from anyone? All right. Whilst I just feel there's something that I would be very, I cannot leave this one out. It's very important to cover. I just want to cover quickly the module for claims and data. This is a module where you do things like data age analysis by funder, by client, consolidated sales reports, sales totals grouped by funders. And you can actually also load remittance advices. Every time your medical aids pay, you can actually do the reconciliation in this system and then use that to follow up the status of those payments, or to find out, to establish, this client, member number, suffix, age, gross amount, funder paid, and so the reason code for the shortfall. Then you can use this as you can download this file if you want, and you can use this for purpose of chasing up patients. You can also import a file if it comes from medical aids and it's in Excel format. You can actually import that file into the system. The system will do the reconciliation for you, so you don't have to capture each status one by one. All right. Still inviting questions. I really could use some questions, please. Thank you. All right, I'm going to assume there are no questions, although, okay, yes, Jackie M, raise the hand, go ahead.
Yes, thank you very much, Chancellor. I think it was quite enlightening, your presentation and everything. My question is on queuing and maybe a mini client relationship management module that I didn't see clearly coming out of the presentation. I've never really used your system, but I've seen it. And it's something that I've seen in other systems where, especially for GPs, they want to see the number of clients who are still queuing outside and those that they've treated, and also the diarized system, where the booking, where there is the booking, and after the booking, like say you've got 7 patients that you've booked for that particular day, and when they come in, I see there's something that's coming there. Yeah, it's good. Then as they come in, they are ticked off automatically. They tick them off so that at least at the end of the day, they're able to see who has come in from the booked clients and who hasn't come in, and also being able to then give them a call, like their assistants then give them a call. And yeah, I've seen that system elsewhere, but yeah, during the presentation, I hadn't seen it. So it may be something that I can explore later on. Thank you.
Okay, thank you so much for that. Thank you so much. It's noted. So what I can show you that relates to that is the client's waiting list, which is for each user. In other words, for each station, each doctor will have their own waiting list. Because what happens that as each patient is seen, they are sent to a particular station. Say, for example, they're sent to see the doctor. Then they begin to appear on that waiting list of that doctor who is logged in. So this is a waiting list. You know, the doctor sees this and they can see, okay, I have these many patients waiting today. And I see name, gender, age, time they were queued. And they can actually see the record by just clicking on that entry. They can already see the whole, before the patient comes in, they can already pick into things like, okay, what's the situation with this client and all that. And then in terms of appointments, appointments can also be made in the system where, you know, there are slots, and on each slot you can schedule a particular patient with some notes for that. However, there's something you did mention, which is a valid additional value or additional convenience, perhaps a correlation of these two, which we've duly taken note of. Thank you.
Right, thank you.
More questions? I really don't want to wrap this up. I'm imagining that we have questions burning. Okay, so I'm going to thank you all for attending. And in terms of contact details, I think we already we already have each other's contacts, but in case you don't, these are our contacts. These are website, it's an email, phone numbers, the 2 phone numbers, they're both on WhatsApp, or you can call, and we'll be able to attend to you. We'll be able to do some more presentations. We're going to be doing more, as I mentioned earlier. This is supposed to be a series where we take up different elements of healthcare provision, but mostly from our angle of experience and expertise, which is the technology side. However, we're going to be arranging different panels and facilitations so that we can also rope in other expertises that are outside our own core technical team, so that we can also cover aspects of the whole subject which are beyond just systems. That way we will be in a position where we are enlightening each other in a more wholesome and more holistic manner, so that at the end of this, we've taken our respective activities to the next level. Otherwise, if there are no other questions, I thank you very much. I wish you all the best in your endeavors, and I look forward to seeing you again. Tentatively, let us agree on 2:30 next week, Monday. But I would like to know from you if there's a better timing, because I know that 2:30 was our suggestion, but you never know. Maybe you prefer weekends, maybe you prefer mornings, maybe midweek. We are available anytime, even in the evening. It doesn't matter really. I mean, we are catering for different time zones, so it's quite possible that some of the people we invited missed this session just because of the time zone. Maybe they thought it was 2:30 p.m. their time. But we'll obviously follow up and establish, because I did get some communications of individuals that had already joined them, tried to join, but it had not started. Then I realized that it was a problem of time zones. In their time, 2:30 p.m. had arrived, but in the time zone I was in, it had not yet arrived. So, and I don't know how many people fall in that category, but we'll try to cater we'll just make our communications more clear in terms of the time zone we're using, so that even, I mean, 2:30 p.m. is sort of friendly for a lot of time zones. The only time zone that would not find it friendly would be, I think, Australia, because they are 14 hours ahead of where I am. Otherwise, the rest of the planet can actually join at approximately this time. It might be very early in the morning, it can be mid-morning for them, it can be late afternoon, but it's generally sort of an average for most people. With that, thank you very much. Until next time.
Thank you very much for your sharing.
You're welcome.
Thank you, Chancellor, for the presentation.
Welcome.